Yep, my name is Richard Betts, and I'm going to be doing a neurological assessment. I've been called to a 69-year-old female. She woke this morning, went to have breakfast, and her husband noticed that she was having some right-sided arm weakness and also a bit confused and slurring in her speech. So the husband called the ambulance. We arrived as a crew at 9 a.m. And by that time the patient had no more symptoms that she had presented with initially at 8 a.m. So starting off with a neurological assessment, obviously as we would come in to see the patient, the first thing we're going to be doing even as we come in to greet the patient is just to look at our ABCs, making sure that her airway is patent, that she's breathing, and just her color. And those are things we observe even as we come up and to introduce ourselves. Hi, my name is Richard with St. John Ambulance. Can you tell me what your name is?
Sarah.
Hi, Sarah. Obviously we've heard that you've had some problems this morning, and we want to just have check you over and see how you're doing. But that would include that we do have to obviously to touch you and to take a set of vitals. Are you happy with that?
Yep.
Okay, great. Obviously, one of the first things that we want to look at is just to obtain what's the level of consciousness of the patient, and we use what's called APU, which is basically seeing if the patient's alert, which in this case she is. Voice, if maybe she's not alert but she responds and opens her eyes into voice. P, pain. So if she doesn't respond, maybe we can give a small pain stimulus, squeezing the finger, and then obtain if she responds to that. Or if there's no response at all, then with the U for unconscious. Now there's a huge number of potential problems that could cause a neurological deficiency, and we use another abbreviations called AEIOU TIPS, which gives a list of different reasons that we could have a patient with a lowered level of consciousness, from alcohol, epilepsy, insulin levels are off, which we'd find with a diabetic patient, overdose, change of medications, underdose, trauma, potentially an infection, psychiatric issues, or in this case, which we found with this patient, had a stroke. So these will all be different causes, reasons that would cause a neurological deficit, lowering her level of consciousness. And obviously there's many differential medical problems that could be included that we would be wanting to look for even as we're doing a neurological assessment, such as the diabetes, just dizziness, headaches, backaches, dementia, Parkinson's, MS, epilepsy, seizures, possible head injury from trauma, just a hemorrhagic bleed within the brain. Obviously, I said earlier, medicine changes, vertigo, problems with the inner ear, infection such as a urinary tract infection, alcohol, psychological, or even potentially even a tumor, which would cause a neurological problem. So as we go in to assess a patient, obviously we have to go very broad and try to narrow down, and that's what in our neurological assessments, what we're trying to do to find out what's the cause of this deficit. We'd obviously do a baseline. We want to get a blood pressure quite quickly to find out if the blood pressure is up, which could have been the cause for the stroke. So we're going to get a full set of baselines, both listening to lungs as well as getting blood sugar, which is quite important, quite quickly. Also, we use another test, which is a quick way to determine if there's just a weakness, and that's using a FAST test, which is looking at, first of all, the patient's face, seeing if there's any drooping on one side. Also looking to see if the person's speaking clearly, if there's any dysphasia. Asking the patient even to stick out their tongue to see if the tongue goes off to one side or is not able to stick it out at all. Also, as in that FAST test, so we've looked at the face, looking at if there's anything that's just off to one side. The arms, we're going to have the patient put out their arms out in front of them, close their eyes, and wait for 10 seconds to watch to see if there's any drooping to one side, drifting to one side. And so this has helped establish that if there is an ongoing blockage, and it could be either hemorrhagic or it could be like a ischemic within the brain. So we've done a FAST test, but obviously at that point we can determine, okay, if it was negative, if the patient did show that there was signs of some type of neurological deficit, then the acuity of that patient would be quite high, and we would want to immediately transport to a hospital. In the case of our patient here, obviously those symptoms it's in FAST negative, so she doesn't have any more neurological deficits. We have a bit more time on scene. We can do a bit more of a full assessment. So other things that we would look at is obviously it would also be the pupils. We look to see if the pupils are pearl, the equal and responding to light. We look to see if they're dilated, both dilated, or one dilated, one pinpoint. If they were both pinpoint, we more think that maybe there's an overdose of opiates, or if there is not equal and not responding to light, that there might be an increase of intracranial pressure that's causing that. We would also just have the patient follow your hands, your fingers, and just to see if there's any kind of ocular nerve damage that's where they're not able, or if there's one of the eyes drifting off to one side. We'd ask the patient to just to take your hands, to squeeze your hands. We can feel if there's equal strength. Also the same thing with their feet. We'd ask them to push against our hands or to bring their feet towards you by putting pressure against your hands. So it's just, again, it's seeing if giving us an idea if there's strength both equally. If the patient is able to, we would have them then stand and just get an idea, having them as they stand with their legs together and their hands to their side, asking them to then close their eyes. And the purpose is to see if there's any drifting. So if they go off one way to the other. Another test that we do is actually just a heel to toe, where they have them walk on a line, one foot after the next, and just seeing if they're able to do that. In all these different tests, it's really to see if it gives indication if there's any problems in the brain, if there's any cranial nerve damage or any deficit. So once we've established that we would then decide, if the patient still is having some neurological deficit. Obviously, the acuity of the patient is going to be higher. In our situation here, our patient is going to be a status 3 of a medium acuity because at this point in time, there's no longer any deficits, neurological deficits. So we would encourage to transport to hospital because obviously that could change. And if en route, even as we're monitoring and watching the patient, if there was any signs and symptoms that would come back again, showing that there is some neurological deficit, obviously the acuity is going to rise to a high acuity, and we could go as transport the patient as a status 2 to hospital. Thank you.